This is Katie Bodine, and we're going to be talking about syndrome of inappropriate ADH secretion today. SIADH. This is that topic that just everybody kind of groans at. It can be very confusing between this. I always had trouble remembering SIADH versus DI. Think about it this way. SIADH starts with an S, it's sad, okay? DI is a daisy. It's relatively straightforward, easy to treat. SIADH usually indicates badness, okay? Not quite as simple. As a brief review, SIADH, ADH is vasopressin, and that is the hormone that's made in the hypothalamus, but then it's stored and released by the posterior pituitary, and it helps control our fluid homeostasis. Okay, this is why we get thirsty and we drink, and it's generally triggered by high plasma osmolality. Right, hot plasma is concentrated, which means we have not enough water in our blood, viscous, so low blood volume. So we might have some low blood pressure. It might be released by stress. So we need our blood pressure a little bit higher, and there are drugs that may also trigger this. It's negative feedback loop. So when our plasma osmolality or osmos are high, we've got nice dilute blood, then it's inhibited. Okay. So to sum it up, ADH is released. It increases water reabsorption back into our blood via the distal nephron. So we reabsorb water into our plasma to keep our plasma nice and balanced, which results in concentrated urine and less dilute plasma. Okay. So SIADH is a syndrome in which we already have low serum osmolality, and ADH continues to be released. Okay, so we continue to absorb water at our kidneys despite already high amounts of water. So we now have very watery blood. We have dilute blood. So keeping it simple, we're soaked inside. SIADH. We're soaked inside from added water, H2O. Okay. So some of the common causes of this are going to be SI, serious illness. This is bad, okay? And then anything that affects our ADH. So this can be cancer and, interestingly, small cell lung carcinoma, as we've heard in other diseases of the endocrine system, like parathyroidism. Small cell lung carcinoma can actually just release ADH on its own. We can have brain tumors, lymphoma, pancreas, duodenal cancers. Those can all secrete, affect ADH secretion. CNS disorders can affect the brain ability to release. So stroke can actually cause this. Subarachnoid hemorrhages, subdural hematomas, psychosis. You can have infections like a brain abscess or Guillain-Barré syndrome. Post-pituitary surgery, we can have the opposite effect, any type of brain surgery actually, and drugs. So in particular, mood stabilizers and anti-epileptics are known to cause SIADH. Infections of the brain or lung, such as sepsis, in particular, can cause issues with our ADH secretion, particularly TB. Okay, so what are the symptoms? This is a little bit counterintuitive. So our initial symptoms are actually kind of consistent with dehydration, even though we're quote unquote soaked inside. We're not really volume overloaded, but our plasma is dilute. And so our symptoms are going to be consistent with hyponatremia, low sodium in our blood. So initially, you can have a headache, nausea, vomiting, muscle cramping, okay? And then this can progress to CNS dysfunction, central nervous dysfunction, when our effective plasma osmos fall below 240. That's not a huge difference, right? It doesn't take much to start having some confusion. So these can be subtle, and can have a little bit of confusion, maybe progressing to hallucination and mood swings. And then they can progress as the sodium continues to be more dilute and continues to fall, to altered personality, lethargy, and confusion. But under 115, this can progress to stupor, neuromuscular hyperexcitability, hyperreflexia, seizures, coma, and actually death can result when we get super hyponatremic. It's scary. So how do we diagnose this? Well, let's first confirm our patient fluid status. Are they hypervolemic, euvolemic, or hypovolemic? Okay. Now, if somebody is hypoosmolar, meaning their blood is already dilute, and you're euvolemic, that person should be excreting large volumes of dilute urine, right? Because the hypothalamus should be receiving that feedback and withholding ADH, because it's going, hey, stop bringing in water. We need to concentrate this volume, and we need more sodium, okay? So if the serum sodium concentration and the serum osmolality are low, and the urine osmolality is inappropriately high, our differential would be volume overload, volume contraction, or SIADH, okay? So euvolemic hyponatremia, always suspect SIADH. If we've seen our patient, we've seen these labs, we should be considering their drugs. So don't just jump to conclusions that this is cancer or some extreme badness. If you see lithium on there, if you see amiodarone, some other drugs, you might want to immediately go, okay, well, I know they're on this drug, it's probably this drug. All right, so if they're not on any medication, we're going to go on to some diagnostic imaging. So think about chest x-ray, and maybe even CNS imaging if they have a focal neurological deficit that might suggest a pituitary adenoma or other cranial intracranial abnormality, as discussed earlier. Now we're going to go on to obtain some laboratory, serum laboratory and urine laboratory analysis. So we want to get our serum and urine osmos and electrolytes. And don't forget about the thyroid. Okay, so we'll get a thyroid and adrenal function to look at as well. In terms of treatment, we are going to treat that underlying cause. We are going to restrict water because our serum is already low in sodium, and that will make it worse. Okay, we want a high salt, high protein diet. And if this is a chronic issue, we could administer a vasopressin receptor antagonist. And we can also, in severe cases, if this person's coming in a stupor, they're going to be admitted to the ICU and given hypertonic saline with extreme caution. Now, this is something that you're going to probably have a nephrologist on hand for, because these people can not have an overcorrection for chronic hyponatremia, right? There's that whole central pontine myelinolysis problem that can happen. You can kill them by increasing that sodium too quickly, and I've seen it happen. So you have to very, very carefully replete the sodium stores. They can give IV or salt tabs, but you're only going to increase that serum sodium no more than 8 milliequivalents per liter in 24 hours. So every 24 hours, say they came in with a sodium of 115, your goal for that day is you're going to be doing every 4-hour labs, and your goal is going to be no greater than 122, 123 that day. Okay. Here are some key points to wrap up our presentation, and references, as well as great resources. Again, those pictures I used in the slide today are from Osmosis if you need to take a deeper dive into pathophysiology, or they use a lot of pictures and diagrams for pathophysiology, and when you understand the pathophys, you understand how to identify and treat your patient. So I highly recommend digging into that a little bit deeper if you need to. Have a great day.